good morning, good afternoon, and good evening. Really a pleasure to host this session where three of us, practitioners from different corners of the world, will be presenting our work where we try and make equitable access possible for low and middle income country participants on online learning. And we have three different aspects from our own work domains to present, and all of them have a common denominator, namely the equity and access, and how the public health and medical education can be scaled in these countries of Global South. My name is Heini Utunen. I work at the World Health Organization's Health Emergencies Program, where I lead the online learning platform openwho.org work. I'm joined today by two associate professors from two distinguished organizations, Dr. Titi Savitri Prihatiningsin is a medical doctor and associate professor from the medical education department of the Faculty of Medicine in University of Qajar. She's also a chair in the CERME, which is the Regional Medical Education Institution of Southeast Asia. Welcome, Dr. Titi. And we have Dr. Matthew Streloff, who's associate professor at Stanford Emergency Medicine Department, and also vice chair of strategy and director of Stanford's Emergency Medical International as we're speaking. Colleagues here will first present their low and middle income country related works, and we start with Dr. Matthew. The floor is yours.
Hello. I'm Dr. Matt Strelo from Stanford University, and I'm going to speak about whether we can use MOOCs to train bedside healthcare workers during a global pandemic. Early on during the COVID-19 pandemic, our team was approached by our partners across the globe, primarily from South Asia, asking whether we could help educate and train bedside healthcare workers on the management of COVID-19 patients. And the primary request centered around whether we could help train doctors to care for patients on ventilators that had COVID-19. And there was a lot of energy and effort focused on the acquisition of ventilators and then managing patients on ventilators. The challenge with this, though, that we detected early on was that the vast majority of healthcare provided in low and middle income countries is not provided by critical care specialty trained physicians or emergency care specialty trained physicians, but it's provided by nurses and non-specialty trained or generalist physicians and other healthcare workers. Additionally, the vast majority of patients with COVID-19 aren't ending up on ventilators, and the real opportunity to potentially save lives was prior to the patient getting that sick, when once they were that sick, it was going to be very difficult to make a difference in their outcomes. So we developed a hypothesis that there would be a substantial demand by non-specialty physician healthcare workers in the detection and early care of COVID-19 patients. So with this in mind, we aim to create a free MOOC designed for bedside healthcare workers in low and middle income countries. To do this, we reached out to our partner at the Vice Provost of Online Learning Office at Stanford called Digital Medic. They, along with us, had significant experience developing online courses for healthcare workers in low and middle income countries. And we reached out to industry partners such as Coursera, edX, and YouTube, along with academic partners from across the United States and some from sub-Saharan Africa. And together we developed a simplified course using easy to recognize imagery that was kind of universal. And we had a bedside focus, really trying to target the healthcare worker that was actually caring for the patient in the detection and early care of COVID-19. We wanted to optimize the course for mobile use so that we knew that providers probably wouldn't have laptop computers or access to computers, but they would have oftentimes access to smartphones or tablets. And we developed 16 short modules, each module lasting about 10 minutes, with the goal that they could intermittently look at these modules throughout the day when they had downtime, instead of long modules that were going to take them away from their general activities. And the total length of the course came out to be about 4 hours, and that included pre-testing, post-testing, and surveys. We saw fairly strong uptake, and at this point, we've had about 100,000 enrollees, with approximately a quarter of our enrollees coming from North America, but only 6% of our enrollees coming from sub-Saharan Africa. And when we break this down further, what we found was that we had strong uptake in middle-income countries, and that's continued to rise, but we had relatively meager uptake in low-income countries, with our early analysis showing only 1% of our course participants were from low-income countries. Now, did we target the right healthcare provider group? When we broke that down, what we saw is that our largest cohort was actually healthcare workers, bedside healthcare workers that were non-physician and non-nurse. So pharmacists, techs, pre-hospital care providers. This was followed closely by physicians and nurses, and then students, broken into those that were practicing clinically and those that weren't. And so we did see that the vast majority of our course participants were bedside healthcare workers. We had a relatively strong completion rate. Typical MOOC course completion rate is, somewhere between 8 and 15%, and ours was ranging around 30% early on, and it's risen all the way up to about 40% currently, likely due to the short duration and design of the course. Looking at knowledge assessment, our goal really was to see whether we could create a universal course, but targeted it towards LMIC providers. And so when we looked at knowledge assessment on post-course and versus pre-course testing, we saw strong knowledge gains despite people coming from different backgrounds. Whether you were in a high-income country or low or middle-income country, the knowledge gains were relatively equivalent. And the same is true when we looked at it by profession. Typically, when I design courses, I spend a lot of time focusing on who is my audience? Is it nurses? Is it pre-hospital care providers? Is it specialty physicians? So trying to design a universal course was quite a challenge. But what we did see here was that we had strong knowledge gains by both physician and non-physician healthcare workers. On our 4-point Likert scale of self-assessment on whether providers felt that they were, improved their knowledge, improved their ability to care for COVID-19 patients, the answer to this question is the one I probably care most about, which is I have received adequate training on caring for patients with COVID-19. And we saw that post-course, most providers agreed with this question, or strongly agreed. Now, we anticipated that providers would just reach out, find this course, and take it. But what were the motivations for taking the course? Why did they reach out? So we looked and we asked and surveyed some of our participants afterwards to say, what are your motivations for taking it? And what we found was that the strongest motivators for taking this was just your personal motivation, right? Which we know is a strong driver. And it also, the fact the course was free and who offered the course actually impacted it quite a bit, versus things that had less of an impact were demanded or recommended by the employer or to earn CME, which we know is not typically a motivating factor in LMICs, where continuing education and continuing medical education are not required for nurses and most physicians. So what about this challenge of low-income country healthcare workers? We came up with 3 theories on why we weren't reaching them. One is they didn't know about the course because we weren't contacting them through their news sources and social media feeds that they prescribe to. The second was they didn't have the technology, bandwidth, or smartphones in order to access the course. And third was that we offered the course primarily in English, and we weren't reaching them in a language that would allow them to learn from the materials. So to combat these things and to try to address them, we developed directed partnerships across a number of locations, including South America, Uganda, and Pakistan. In South America, we focused on leveraging healthcare workers and physician network that we had there across emergency medicine to translate the course materials and localize the content a little bit more. In Pakistan, we focused on these telehealth workers. The government of Pakistan had contracted with female physicians that worked from home to provide telehealth services to COVID-19 patients. And so we built a telehealth module, had them take the course, and then conducted webinars to answer questions for about 400 Pakistani female physicians. And in Uganda, the government decided that their healthcare workers and hospitals needed further training. And so we worked with them to provide this course, and then as part of a blended learning approach where they got bedside training as well from specialty physicians. And our most recent partnership has been with AfriHealth to try to specifically target Sub-Saharan and Africa. And here, this group, AfriHealth, is a Pan-African organization that has now co-branded the course and is working to help us translate it into French and Portuguese. So our challenges and our next steps. One of the big challenges is that this is constantly changing. So MOOCs during a pandemic can't be static. They've got to constantly be iterating the content, and we've been working to do that. Language barriers are a significant challenge, and we've started using AI-assisted translation to improve that. Course completion rates, although strong, are nowhere near the 70 to 80% I'd like to see. We got to figure out how we can continue to improve that in a course that's this short. And then our lower usage, as I've previously mentioned, in low-income countries. So we continue to analyze that, to form these directed partnerships, and to see whether we can improve those. So in conclusion, I want to thank all of the partners and all of the providers that helped build the course. And I want to thank the conference organizers for allowing me to speak today.
Thank you, Dr. Matthew. We have a lot of interesting findings from your session, and we'll now go straight to hear the presentation from Dr. Titi on the work that she's been conducting on the competency-based medical and public health education in CRME. Dr. Titi, floor is yours.
Good morning, afternoon, and evening. We know that at the moment, pandemic COVID-19 is still going on, and we don't know yet when it will end. However, we need to continue our health profession educations. In these sessions, I would like to discuss to what extent distance and distributed learning could increase access and equity during and after COVID-19 pandemic in CRME context. There are three topics that I would like to present. The first is principles in competence-based education. The second is health profession education responses to pandemic COVID-19 in CRME context. And then is distance and distributed learning solution. First, principles in competence-based educations. We know that at the moment, in many countries, competence-based medical educations have been implemented, and it is considered the most appropriate education approach to educate health profession. And also, we know that by applying competence-based education, we have to have a curriculum design backward, and we have to create many learning opportunities. And also, we need to make sure that there is a constructive alignment between the learning outcomes or the competencies, the assessment, and the learning activities. Secondly, how the health profession education responds to pandemic COVID-19 in CRME context. In these presentations, I use CRME as the context because in CRME, we have low-income countries as well as we have middle-income countries. These are the members of CRME. We did an online survey using Google Forms, and we had 1/3 32 medical teachers as respondents. We asked them a number of questions. They are from India, Thailand, Indonesia, Nepal, and from other countries in Siarame. We asked about what instructional strategies that they use for facilitating the achievement of competencies. Using qualitative method, we come up with 20 strategies from synchronous online lectures down to live broadcasts of real patient encounter. So there are a lot of varieties of how medical teachers have struggled to continue the teaching learning process by using whatever means available to them. And here from this survey, it is founded that most teachers use synchronous online lectures for the competencies at the knows-how level. And also for the shows and the does level, they use synchronous online lectures. So synchronous online lectures have become the most method that are used by many medical teachers, followed by online problem-based learning, simulation lab, and then case study peer review and video clip. What are the challenges? These are some of the answers. We know that in low-income countries, they have insufficient resources in terms of IT infrastructures and digital technology. Lack of skilled and well-trained educators in distance learning. Many teachers are not used to distance learning applied in medical and health profession education. As the results, because a lot of medical teachers or health profession education teachers do not know how to do the clinical educations by distance learning. So many sessions in clinical rotations and clinical educations have been suspended. Skills examinations and licensing examinations are also canceled or suspended. And then because there is sudden disruptions, many move to online teaching, but just to shift from face-to-face to online teaching without designing new curriculum. And in many places, especially in remote areas, they lack of access to internet and electricity. And also a lack of opportunities for practicing communication skill with patients and colleagues. So a lot of questions. Do we produce the same competence health professionals before and after pandemic? Or we produce different health professionals because they are less competent than the before pandemic COVID-19. So is distant and distributed learning a solution? There is publications by Horton W. in 2012. He said that at its best, e-learning is as good as the best classroom learning. And at its worst, it is as bad as the worst classroom learning. The difference is design. So we must trust and we must believe that by applying distance and distributed learning, we need to produce the same level of competencies of health professions. There are a lot of interchangeably terminologies have been used, like distance learning, distributed learning, online learning, e-learning, virtual learning, and flexible learning. But in these sessions, we are focusing on the distributed learning. So what is distributed learning? Jim Levin explained that it is perspective on learning that examines the distributions of learning in space and time and the mediation that crosses the distributions. Another definitions from Victor and Hart 2016. Distributed learning is an umbrella terms including one or more blended learning, learning that combines instructor-led training with web-based training and other learning activities outside the classroom. And then mobile learning, learning that occurs on a portable device such as tablet or smartphone. or informal learning, learning that occurs outside the formal learning environment. This type of learning is facilitated by social interactions. Obsidian distributed learning model, as described by Victor, especially focus on the three aspects that are needed in the distributed learning. That is technology, experience, and people. However, in low-income and middle-income countries, we cannot overnight catch up with the advancements of technology. Therefore, we need to hold the principles of Obsidian distributed learning. The first is blended, using various combinations of instructor-led training, web-based training, and mobile learning. In case we don't have web-based and mobile learning, we can use instruction-led training. And then to maximize the collaborative learning, including partner and group experiences, and it can be spread over time, we use just-in-time learning that occurs at the point of need along with performance support, and then focus on competency development rather than on knowledge growth. And also in Victor and Hart 2016, it is explained there are three guiding principles of Obsidian distributed learning. The first is fully learner-centered. The second is learning should be blended. And the third is learning should be a social experiences. So in the low-income and middle-income countries, we need to explore further how we can apply distributed learning. There are many learning resources out there. There are many real patients, real situations in societies, in communities, in villages. There are many hospitals, many health centers that can be used by medical and health profession students that are distributed in various geographical areas. So this is the references. So we think to answer how to continue the health profession educations during and after COVID-19 pandemic, I think distributed learning is the answer. Thank you.
And thank you for this very interesting presentation. And after the sessions now, we will have a chance for a short Q&A, questions and answers session in which colleagues are and myself are able to answer your questions. I'm Heini Utunen from the World Health Organization's Health Emergencies Program, and I lead the Open WHO platform, which is an online learning platform for health emergencies, servicing the world with WHO's technical guidance and evidence-based learning. Open WHO just this month celebrated the four years anniversary. We've been in operation for 4 years, delivering learning mainly for low and middle income countries. And I have some findings from the platform now during the COVID-19, and also some interesting changes in the use of online learning of our health emergency learning platform over the pandemic. So it is a pleasure to present, and this presentation is put together by many talented colleagues with Ms. Ngui Ndiaye, who's provided the most support for this data and evidence leading to this presentation. So overall, here are some figures from the Open WHO platform. We are currently hosting 5.3 million course enrollments. These course enrollments are across almost 100 different course topics. We have 34 courses for COVID-19 and currently 61 other health topics as courses on the platform. We have very high completion rates, almost 60% completion rates on an average on the platform, meaning we've issued more than 2.8 million certificates so far. And this has really been a big change during the pandemic. Our completion rate before the pandemic was less than 30%, and now it's nearing 60%. So the learners are really staying and completing the courses. Our learning materials are in 54 different languages and counting. And out of those languages, 15 are languages of the most vulnerable populations in the world, mainly from Africa and Asia. And this is one of the key values for us on OpenWHO. We try and make the effort to provide materials in languages of the most vulnerable populations. We host materials for 42 languages of the least developed 46 countries. So we are in particular trying to reach the most vulnerable, least developed countries. We have so far translated almost 10 million words. It's a huge figure. And thanks to the pandemic surge, we've had volunteers from all around the world to help translate into these dozens and dozens of languages. We are hosting almost 1,800 videos, and it's more than 30,000 hours of videos watched on the platform. Here as a background on OpenWHO, so our key assets are really on the scalability. So already 4 years ago, when we started designing and planning together with HPI, this platform, the number one priority for us was the scalability, to go into massive user numbers in an event of the pandemic. And now we've been on this pandemic real-time test for 1.5 years, and we can say that we've successfully met the learning demand and need of the world in a massive global pandemic. And here's some figures. We've gone from 1.5 years ago, we had less than 200,000 enrollments on the platform. Today, it's more than 5.3 million enrollments. So we've grown exponentially over the past 1.5 years. We have currently 70 technical and expert teams producing courses, all in dispersed manner, everybody working mainly from home, from all over the world. And we have systems in place where we can produce all the technical content. And when I say technical, it's the expert content of WHO, real time from anywhere in the world. We are also hosting resources and materials for all other infectious diseases, not only COVID-19. So we cover about 20 other diseases on the platform, infectious diseases. Serving the vulnerable is one of the very foundational values for not only for OpenWHO, but for WHO as a whole. So for us, it has meant that we make available all materials free, accessible, open source, and in low bandwidth adjusted formats. All the materials work from any gadget, device, mobile, desktop, tablet, any format the user wants to use. And we have offline formats and downloadable formats. And this is one of our key priority, to have materials at ease for users so that they can be used anywhere and in a way the learner wants to use them. And we believe this is behind the quite high numbers, the successful enrollments on the platform, that the usability of the materials is very high in different type of internet environments and for different type of learners. We've really expedited this language work as mentioned, and in particular for the populations, the languages by vulnerable populations. And the multilingualism for us is natural domain. The United Nations has 6 official languages, and this is usually the starting point for our course and content production. We aim to publish initially in all 6 UN languages and Portuguese, and then continue into the national and local languages. And this work we've done together with WHO country and regional offices. WHO is present in 130 countries, and this has been a big crowdsourcing effort, along with dozens and dozens of volunteers who've come up and started translating into Indian Sign Language, into 14 different African languages, and many more. And we have also institutes that work with us, such as Translators Without Borders, who translate also the languages that have a less of a commercial capability and interest. So we are aligning well our work with the Translators Without Borders, our long-term partner. And we work with other platforms, such as Pan American Health Organization's Virtual Campus, which is hosted of Panama, and we are collaborating in the Spanish and Portuguese courses, where all our courses are translated into these two languages and also hosted, bringing us almost 500,000 additional learners. And interestingly, the multi-channel, multi-platform publishing during the pandemic has been very popular. For instance, Brazilian health institutes are hosting our learning resources and have 130,000 additional Portuguese users in Brazil on their own platform, hosting OpenWHO courses at their domain, at the ease for health workers in Brazil. So this all to say that these are the ways and efforts we are making to ensure access and equitability in learning through the online means. And it's been working well, but I'll be happy to also show more results tangibly what it means having this type of formats and resources. Here, a recent world map on OpenWHO's country enrollments, so where the courses are used at most, and you sort of can see that they're somewhere starting in the southern hemisphere. We have quite strong use case, and it is true that during the pandemic we've actually increased the platform use in the low and middle income countries. Before the pandemic, those countries accounted for 50% of the enrollments, and now currently more than 70% of our enrollments derive from the low and middle income countries, which is really, we are happy to see this development. But we have use case in all countries and territories, as WHO states, from all around the world. So we are really happy to reach every corner of the world. Here's some data from March this year, really showing that the middle income countries are using the platform the most. 70% of the use is in middle income countries, with India leading. Only 3.4% of the use is in the low income countries, and this is very much in line what Dr. Matthew was mentioning here before, that we are also struggling to see how we can reach those frontline workers and personnel who needs the evidence-based learning materials in low income countries. We've, however, noted that over the pandemic, the use case in Global South of OpenWHO has equalized in that before the pandemic, there was really Africa focus. Africa use case used to be more than 25% of the platform enrollments. Currently, it's less than 8%. We have more use from South America and Asia than ever before on the platform. And this naturally is explained by the fact that earlier the infectious disease materials such as yellow fever, meningitis, Ebola, Rift Valley fever, and many others were mainly utilized by our African learners. And now with the COVID-19 pandemic, there are many more strong use case countries from also other regions, not only Africa. So in the top 10 low and middle income country list, India is always leading. It's also a big population, but also very keen on online learning use. But equally, many of the South American countries have emerged on OpenWHO's user lists. And that is also due to the fact that we've started really investing on the Spanish course materials. We didn't host Spanish materials at the scale we are doing currently during the pandemic, and we've really noted that the Spanish language users' preference is always to use the Spanish, and we are therefore very happy that these resources have found their use in the South America. Here's a list of top COVID-19 courses and their popularity in the low and middle income countries. And the introduction to COVID-19 is by far the most popular course in low and middle income countries, followed by infection prevention and control, and the UN country team preparedness and response course. So these are quite naturally the topical course titles popular in the low and middle income countries. Here's just to show the comparison before the pandemic. As said, that time the low-income countries were much higher on the course use than what they are now, and in particular Africa. The middle-income country use has increased the most, gone from 40% to 70%, whereas the high-income country use has decreased during the pandemic. And of course, here before the pandemic, the use of courses is very different popular courses. That time we only had one coronavirus course on the Middle Eastern respiratory syndrome, and all the other courses are actually related to the antimicrobial stewardship or Ebola or risk communications and pandemic and epidemic prone diseases that were leading before the COVID-19. It needs to be said that the antimicrobial stewardship course was the more popular course in the middle and high income countries and not in the top 10 in the low income countries. So we also see different use patterns of the courses in these different three categories of countries' income level, which is important for us to understand where to target and how to place the courses and in which languages. And simultaneously, we are doing work where we are scoping more what type of epidemic and infectious diseases we have and in which countries, and what type of languages are needed, also for other diseases than COVID-19. So for plague, for meningitis, for many of these other infectious diseases courses. We were just lately taking some stock on the course users experience on our 2 vaccination courses that went live end of 2020. And we in particular wanted to look at the barriers. So we of course looked at the motivation and interest and affiliation, the usual interesting course statistics. But then we also surveyed on what are the barriers to join the vaccine courses on OpenWHO. And quite interestingly, out of the almost 3,000 respondents to these surveys, 56% said they had no barriers whatsoever. It went smooth. 30% of the responders mentioned internet connection issues being a barrier. There were system, OpenWHO, IT-related issues for 10%, some difficulty navigating, not enough time to complete the courses was also perceived as a barrier, and the language by 8% of the responders. And then there were a set of other questions, other topics of causing a barrier. And when looking more in detail, this one can of course guess, but this is coming straight from the course survey. When you look at the internet connectivity issues, you see with the map here highlighted in yellow that it's really in countries like Cameroon, Ethiopia, South Sudan, Ghana, Zimbabwe, Uganda, Yemen, Afghanistan, where the responders had indicated issues with the internet connectivity. And it goes to say that the low bandwidth format packaging of materials is very important when trying and reaching the users in countries with the likely compromised internet connectivities. We also looked at the languages. So there were responders who felt that there were language constituted a barrier. At that time, the course was only available in English, and it informs us that in several countries of Global South, there is a desire to have the materials in languages, local languages, and languages spoken in the country. More national languages are needed, and this we can also see when we look our whole of platform results, the top languages here. For instance, the Indian Sign Language and Hindi are very popular, of course, because we have such a big numbers of users from India. 25% of our users are from India. But for instance, the Indian Sign Language course is consumed all over the world. It's our only sign language resource, and it's very popular all over the world in all continents. So it hosts 55,000 learners and is being utilized all over the world. So it's a service not only for the Indian Sign Language community, but also beyond. And this is a global feature and phenomena that we are thankfully seeing, that the learning travels across the world. When it's produced, it can host learners not only in that one given country, but also beyond. Just generally speaking, here are some country and course top lists, and more details and interesting survey findings and research findings can be found on OpenWHO, where we collect all the publications we publish. We're just now working to detail how our different user groups are approaching and completing the learning journeys. This is a global figure, but students, learners identifying themselves as students are our biggest category, almost 38% of the OpenWHO learners, followed by healthcare professionals, 23%, and then other non-identified background is very large as well, and then evenly split in NGOs, international organizations, ministries, and health expertise in different areas. We are looking into detailing this for low and middle income countries and see the motivation of participation to courses in particular from low and middle income countries. And to finish off, this is just to show that we are investing on serving the countries and producing materials in the formats that the countries and our country offices have been leading this work in establishing translated versions of the key resources we have on the platform and publishing them in their own channels. So we've just launched 6 channels, and many more are coming, and we hope and see that in the future, just like in the example of Ukraine, the country is now producing their own country-derived learning resources on the platform. And this is the direction where we want to go, more focused, localized resources for the responders that can be hosted on this platform. With these findings, I thank you for your time, and we'll be joining the question and answer session. Thank you.